Good morning, everybody. I'm George Mjaess from the St. Joseph University in Beirut, Lebanon. Today I'm going to be presenting about laparoscopic transperitoneal pudendal nerve and artery release for pudendal entrapment syndrome. I have no conflict of interest. Pudendal nerve can be entrapped at different anatomical sites along with the pudendal artery. The two main entrapment locations remain between the sacrospinous and the sacrotuberous ligaments and the Alcock canal. Pudendal nerve and artery entrapment is an underdiagnosed condition in clinical practice that causes mainly perineal pain and sexual dysfunction, but also urinary and rectal symptoms. Historically, and after failure of the conservative management, open invasive pudendal nerve decompression was done with poor outcomes, and this is why the non-criteria which were put to standardize the diagnosis were very selective in order to minimize overtreatment by such an invasive approach. This was until the advent of laparoscopic pudendal release, which allowed a minimally invasive surgery with an easy access and gentle blood-free dissection. This has therefore led to widening of surgical indications. The aim of our study was to assess the safety, feasibility, and functional outcomes of laparoscopic transperitoneal pudendal nerve and artery release in patients with pudendal nerve entrapment syndrome with both a short and long-term follow-up. 235 patients with pudendal nerve entrapment were included in the study, and they underwent laparoscopic transperitoneal pudendal nerve and artery release. Post-operative complications, according to the Clavien-Dindo classification, were recorded both on a short and long-term follow-up. Those are briefly the surgery steps. First, we develop the obturator space and we carry the dissection medially to the obturator vein. The coccygeus muscle fibers must be cut and released to have access to the ischial spine on which the surgeon's forceps is pointing in figure C. Finally, we arrive to the entry to the Alcock canal. Here, we can clearly see the pudendal vein and artery entering the Alcock canal. The pudendal nerve is lateral to the artery and not visible in the image. The goal of the surgery is to liberate the pudendal elements from the ischiatic spine to the Alcock canal and transpose them medially. After assessing the post-operative outcomes in the total cohort, a prospective cohort of 32 patients was evaluated for functional outcomes before and at least 24 months after surgery. The main outcomes that were assessed are periodynia using visual analog scale, urinary symptoms using the urinary symptom profile, erectile function using the IIEF5, and bowel function using the Patient Assessment of Constipation Symptoms PAC-SYM score. The mean operative time per site was 33 minutes, and the hospital length of stay was 2 days for the majority of patients. No significant blood loss and no serious Clavien-Dindo 3 and 4 post-operative complications were noted. Penile or perineal paresthesia or hyperesthesia was the most frequent post-operative complaint. However, it was transitory for 3 months, after which all patients were free of symptoms. As for functional outcomes, perineal pain decreased significantly from a mean of VAS of 7 to a mean of 2. Erectile function improved significantly after surgery, and we think it is most probably due to the artery entrapment, since immediate results were seen after surgery. Constipation also decreased significantly after surgery. As for the urinary symptoms, improvement was only noted for the dysuria domain. No significant differences were found between before and after surgery for stress urinary incontinence and overactive bladder symptoms. So to conclude, laparoscopic pudendal nerve and artery release is both a fast and safe surgery with promising functional outcomes on pudendal neuralgia, erectile function, lower urinary tract symptoms, and constipation. Thank you for your attention.